So I'm Leo Gordon at Northwestern University, Feinberg School of Medicine, and the Robert H. Lurie Comprehensive Cancer Center. I want to thank John and the organizers for asking me to talk about novel therapeutic approaches in chronic lymphocytic leukemia. And what I'll try to do is summarize a variety of features. Talk first about prognostic markers, specifically focusing a bit on deletion 17p and mutation status. Talk a little about challenges that we face to the use of novel agents in CLL and actually in other lymphomas as well. And that's especially relevant in the era of oral therapies when we talk about adherence and potential cost implications, adherence implications to oral therapies. We'll talk a little bit and focus on recent FDA approvals, and we'll try and focus on the Resonate 1 and 2 studies, the Ascend study, and the Elevate studies with acalabrutinib in both treatment-naive and relapsed refractory patients, and then touch a bit on a recent approval of duvelisib on the DUO study, and then the last few minutes try and focus on a variety of PI3 kinase inhibitors, idelalisib, duvelisib, and the newest one currently in clinical trials, umbralisib. So first, the use of prognostic markers. Just a couple of things about CLL that I think are worth reviewing again. First, as all of you know, there's a malignancy of CD5 positive B cells. The expression of immunoglobulin by each case is clonal, meaning that each patient's leukemia cells really make up only one antibody as opposed to normal B lymphocytes. About half of all cases express immunoglobulin with variable region genes or IGHV genes that have some somatic mutation. We know also that the immunoglobulin repertoire of patients with CLL is highly restricted compared to that of normal B cells. The origin of B cells is really divided into two main subsets: pre-germinal center B cells, or pre-GCs, and post-germinal center B cells, post-GCs. And we think of the IGHV mutation status as a surrogate marker for the cell of origin, so that the unmutated cases probably represent pre-germinal center origin, and the mutated cases probably represent post-germinal center origin. This was reviewed by Tom Kipps in a number of occasions. Immunoglobulins expressed by CLL B cells are highly restricted, indicating selection of B cells with certain types of immunoglobulin receptor signaling. We know that the clinical course of patients with CLL is heterogeneous. Most patients have a fairly indolent course and don't require treatment for many years. Other patients may have an aggressive course and require intervention, and that might be because of bone marrow failure causing cytopenias. That might be because of autoimmune hemolysis or thrombocytopenia, recurrent infections, or the development of secondary malignancies. I would say that the decision to initiate therapy in CLL, at least to my view, besides some hard, fast rules and laboratory values and physical exam findings, also represents a bit of a gestalt. And we have to begin to recognize those patients that we think are going to require treatment. We do know that survival according to IGHV mutation status is summarized really in this slide from blood back in 1999 by Hamblin et al. We know that if you look at all patients, the mutated patients have a better outcome in red than unmutated patients in the black line. And then if you look at those patients with early stage, the Menet stage A patients, again, even that group, mutated patients seem to do better than unmutated patients. The similar data exist, and we won't have time to go into this in detail, but P53 mutations or P53 deletions or TP53 mutations also confers a negative prognostic impact, and we'll see how that plays out as we begin to talk about some of the clinical trials. There are challenges associated with some of the new novel agents that are used in CLL. These agents are, for the most part, oral agents, and they come with a very unique set of problems and challenges. So much so that in 2017, we had a workshop in the Lymphoma Research Foundation specifically addressing this concept and focused on a number of things. And we'll touch on these new healthcare models, polypharmacy, now the use of multiple oral agents, hard to control, hard to regulate, hard to measure adherence. Also, the emergence of adverse events, which you might not see when you're not seeing these patients maybe until 3-month intervals or 4-month intervals, and the cost and financial burden that some of these oral agents have on patients. And a lot of these factors kind of coalesce and intersect and intertwine, but some of them are listed here. They're personal factors, emotional state of the patient, social support, socioeconomic status, intersecting with a variety of treatment factors, reasons people are being treated, the schedule, side effects, costs of treatment, and then interaction with the healthcare system, relationship with medical providers, satisfaction with care, insurance coverage, and proximity of patients to their medical team. All those things may impact adherence to therapy and persistence of the disease. And people have looked at this. Actually, this is a study, actually 2 studies that were published in the Journal of Clinical Oncology in 2006, and then again in 2010. The first is an abstract, and the second sort of a summary of that. On the left, and this is with imatinib, so this is a drug used in CML, and adherence to imatinib. And what's interesting on the slide on the left, the panel on the left, that only about 40% of patients were more than 90% adherent, to use that as a cutoff, to administration of the drug. And over time, that gets worse. You can see as this slide on this graph, it goes down. Does that translate into outcome? It appears to. If you look at, they measured 6-year probability of a major molecular response according to adherence. In blue on the top, those patients with adherence of not greater than 90% had a much greater chance of achieving a molecular remission in CML than those patients who had adherence at less than 90%. So that small differences lead to large differences in outcome. So I think important data. In CLL, we have data that Jennifer Brown and Paul Barr presented. This is Paul Barr's data, adherence and response to ibrutinib in CLL. On the left, you have progression-free survival in all patients where the adherence was greater than the mean dose intensity in yellow, and then less than the mean dose intensity in blue. This is progression-free survival, clearly differences in outcome. And if you look at this panel B, this is in patients with deletion 17p or P50 or TP53 mutation by 8 weeks. Again, major differences in outcome. And then finally, on the right, this is the overall survival by the same mean adherence. So again, it plays a role in CLL, and these are data from Jennifer Brown, published in 2017, suggesting that the incidence of atrial fibrillation on ibrutinib goes up over time. These are unadjusted on the left and adjusted for comorbidities, seeing that over time we're seeing something about a 10 to 12% incidence of atrial fibrillation in patients taking ibrutinib, and that really plays a major role in outcome, as I showed you earlier. So what can we do about this? There are certain recommendations that we made in this workshop. It's important to talk to patients about instructions and give detailed instructions on missed doses. Ask about adherence without being judgmental about it. I think that's a concern patients may have. Did you take your medication? Yes or no, without judgment as to what the answer is. mobile apps, and there's one from the Lymphoma Research Foundation. There are others that help patients monitor their medications, education about side effects, discussion about drug interactions. I think electronic healthcare records are going to make this a little bit easier. Electronic devices are being piloted. Learning from other diseases, I showed you data from CML, and then registries to capture emerging toxicities that occur in past clinical trials. So certain unique problems that we have. I'm going to turn to FDA approvals in this disease. We'll focus on acalabrutinib, ibrutinib, and Rituxan, and venetoclax, some of the more recent approvals in CLL. Duvelisib as third-line treatment, ibrutinib and obinutuzumab as first-line, and then just in May of last year, venetoclax as first-line treatment. Raises an interesting question on what should be our first approach to this disease, and then acalabrutinib, and then more recently ibrutinib and Rituxan as first-line treatment. And the clinical trials that are associated with those are listed, and I can get those to you available. So a RESONATE study was one of the first to look at ibrutinib. This is patients with previous treatment. Oral ibrutinib was compared with ofatumumab as a single agent. I would argue perhaps a loaded study, but in any case showed a fairly striking improvement. Median follow-up of this study was 64 months. The median treatment duration was 41 months with ibrutinib and 5 months with ofatumumab. This was stopped early, and I think clearly demonstrated ibrutinib as a better second-line treatment. And not only, if we look at subsets, patient populations, in the intent to treat population on the left, in yellow versus in blue, marked improvement in progression-free survival. If you look at the higher risk groups, deletion 17p, TP53 mutation, deletion 11q, and or unmutated IGHV, again, ibrutinib over ofatumumab. If you look within the ibrutinib arm, not a striking difference between deletion 17p, deletion 11q, or neither, suggesting that maybe ibrutinib can overcome some of the inherent negative prognostic factors. That also holds for the IGHV mutation status. RESONATE-2 followed up on that. This is an international randomized phase 3 trial for patients with treatment-naive CLL, and this is where ibrutinib was compared to an old standby, chlorambucil, given in pulse fashion, as indicated on this slide. And remember that no warfarin was allowed in some of the early ibrutinib trials, and that comes back to us now as we're seeing more patients with atrial fibrillation. So again, the data in RESONATE-2, 5-year follow-up suggests ibrutinib over chlorambucil, progression-free survival, and with some benefit in overall survival, although not statistically significant, but clearly in progression-free survival. And there are several other trials. This is an ECOG trial, Tate-Shanafelt, published in the New England Journal in 2019, comparing ibrutinib and rituximab. And this is the reason this has now been approved. This is for patients with untreated CLL compared with what was then considered by many to be a standard and may still be in mutated patients, the FCR regimen. So in a fairly straightforward phase 3 trial. If you look at the data, progression-free survival on the left, in all patients, ibrutinib in red compared with FCR, and then on the right, in patients with IGHV unmutated, again, an improvement in overall outcome for ibrutinib compared with FCR. If you look then at Jennifer Wyack's publication and presentation in late 2018, again, ibrutinib, the BTK inhibitor, ibrutinib with Rituxan compared with chemotherapy, a standard chemotherapy regimen, bendamustine and Rituxan. Crossover to ibrutinib was allowed. Interesting in this study if you look at these data, you can see that there is, in terms of progression-free survival, a striking difference in improvement with ibrutinib either alone or in combination with Rituxan. That didn't seem to matter compared with bendamustine and Rituxan. But bear in mind that these curves begin to separate somewhere between 12 and 18 months. Ibrutinib is continued in both of these arms. Ibrutinib, bendamustine and Rituxan stops at 6 months of treatment. So basically, one can argue this is kind of comparing maintenance treatment to no maintenance treatment. And I think it's clear that ibrutinib continued lifetime until progression is better in terms of progression-free survival than bendamustine and Rituxan. Where should this fit? In the ASCEND trial, presented by Paolo Gia at EHA and later in Lancet Oncology, 310 patients with relapsed refractory CLL. Acalabrutinib was compared with investigator's choice, which was either Rituxan and idelalisib, a PI3 kinase inhibitor, or bendamustine plus Rituxan. Median follow-up was 16 months. Median follow-up 16-month progression-free survival versus 16 months with other regimen. 12-month progression-free survival was 88% versus 68% with Rituxan idelalisib. And there's an advantage to the acalabrutinib across all subgroups. Since crossover was allowed, we did not see an improvement in overall survival. And if you look at the data, in red acalabrutinib and in blue investigator's choice, once again, however, though, the investigator's choice, at least with the bendamustine Rituxan arm, was stopped at 6 months, and the acalabrutinib is continued. And this is just summarizing the ELEVATE treatment-naive study. Again, obinutuzumab, chlorambucil, acal, and acal plus obinutuzumab. And what we find is that the chlorambucil plus obinutuzumab, this curve, did worse than either of the acalabrutinib containing arms in the treatment. This is in the treatment-naive group. This is presented by Jeff Sharman at ASH last year. The introduction of venetoclax, a BCL2 inhibitor, has changed the game a little bit, I think. And just to remind you that the way this set of drugs works is that they basically release pro-death proteins, BAX, BAC, BIM, and TBID, from being sequestered by the pro-survival proteins BCL2, BCL-XL, by blocking this association between the pro-survival and the pro-death proteins by inhibiting this binding. These drugs are BH3 mimetics, and they release the pro-death proteins, allowing apoptosis to occur. So this is a first-line treatment that Fisher presented in the New England Journal in 2019, the CLL-14 study. Venetoclax plus obinutuzumab was again compared to the control of chlorambucil plus obinutuzumab. These are patients who had SIRS score of greater than 6, creatinine clearance that was less than 70, but they had coexisting medical conditions, so that's why they were able to give chlorambucil and obinutuzumab in 2015, 16, 17, and 18. I think that this is the comparison, and then what we find is that the venetoclax and obinutuzumab progression-free survival, once again, which is the endpoint for most of these studies, did much better than chlorambucil plus obinutuzumab, p less than 0.001, and a hazard ratio as shown 0.35. So the question then becomes, as we have venetoclax and obinutuzumab as a first-line treatment, should we use that, or should we use ibrutinib as first-line treatment for patients with CLL? The data favoring ibrutinib suggests that there are long-term efficacy data, convenience. There's no TLS monitoring. There are phase 3 data compared with FCR and bendamustine Rituxan, and there are more data for efficacy of venetoclax at the time of ibrutinib progression. That favors ibrutinib. On the other hand, venetoclax has the potential for 1-year time-limited therapy based on molecular responses. There's no known cardiac or bleeding risk, as there are with ibrutinib, and increase over time with ibrutinib. less concern for long-term adherence, the adherence problem I mentioned earlier, and the potential for cost saving, indeed, if 1 year of treatment results in durable responses. So I think that's an open question. Finally, last few slides, we're going to talk about PI3 kinase inhibitors in CLL, idelalisib, duvelisib, and the newest kid on the block, umbralisib. So the first generation PI3 kinase inhibitors, idelalisib, second generation umbralisib, and there's dual PI3 kinase inhibitor, duvelisib, which is now approved. This is idelalisib plus Rituxan versus placebo plus Rituxan. Richard Furman in the New England Journal in 2014. This is in a very sick group of patients, heavily treated, a lot of comorbidities. You could make the case for Rituxan plus placebo in relapsed refractory CLL. You couldn't do that in a different group of patients. But compared to idelalisib and Rituxan, these are the waterfall plots, clearly on the left, better than on the right, and progression-free survival and a suggestion of overall survival benefit. But again, this follow-up is short, a very sick group of patients. And this is the so-called DUO study, which led to the FDA approval of this drug as third-line treatment in September 2018. And what you see on the graph on the chart on the left is that this overall response rate is better compared to the ofatumumab control, and lymph node response 85% versus ofatumumab 15%. And this is duvelisib median progression-free survival in blue compared with ofatumumab in red. This was presented by Ian Flynn in Blood in 2018 and Jennifer Brown and also in Blood in 2018. So the newest PI3 kinase inhibitor, umbralisib, interesting drug, inhibitor of the isoform P110 delta, structurally distinct, limited inhibition of CYP450, and PK profile allows once a day dosing, perhaps an advantage. Phase 1 data are shown here, different dose schedules. And this is in patients with many hemalignancies, CLL, Hodgkin's, T-cell lymphoma, other non-Hodgkin's lymphomas in a phase 1 study. But the phase 2 study that Paul Barr is currently doing is a combination of umbralisib, the PI3 kinase inhibitor, ublituximab, which is a novel CD20 antibody, plus venetoclax in patients with relapsed refractory CLL. And the way this is done is ublituximab, which is the antibody, is given together with umbralisib initially as a run-in, and then starting in cycle 4, venetoclax is added after a standard 5-week ramp-up up to 400 milligrams, and then patients are continued only if they're MRD positive at the end of treatment. The study is ongoing, and this is going to look at 3 cohorts: previously treated CLL that are not refractory to prior BTK inhibitor, previously treated CLL that are BTK refractory, and patients who have never been treated before, about 60 patients on that trial. And this is how it's going to be given: ublituximab and umbralisib, cycle 1 through 3, all 3 drugs, cycle 4 through 6, and then umbralisib and venetoclax without the ublituximab, without the CD20 antibody, and cycle 7 through 24. Patients will then have MRD analysis. If they're negative, they're off treatment. If they're positive, and this is by multi-flow analysis, they continue with umbralisib monotherapy. So I'd like to thank you for your attention and time, and we'll take questions in the Q&A sessions later. Thank you very much.